Let's talk about the effect that DTR has on a typical dental patient.
Relatively fast way to resolve a lot of head and neck discomfort, or let's say jaw and head discomfort.
Right.
But it's not a straight line to symptom resolution. There's a process of healing, unwinding all the stress and tension that the bite has caused. Takes, for some people, 2 to 4 weeks, for other people 4 to 6 months, 8 months, and unfortunately there isn't any way to know if that typical dental patient is a slow healer or a fast healer. And you really can't know until you treat them and see how fast their muscles respond and how quickly they start to lose symptoms.
Well, we're doing our best to try to figure out ways of screening people to make sure that they're amenable, but you're right, until you do it, you don't know 100%.
Right.
Imaging, CT, MRI, we're adding all kinds of protocols to the whole spiel. What should a patient look for in a dentist who claims to be utilizing the DTR therapy properly?
That they've been trained.
Okay.
They've had training in the chair, not that they read a paper on it or they attended a lecture for an hour and they heard that this works and they want to try it because theoretically they think they understand it. It's a very high precision occlusal therapy. It's not your average bite adjustment, and even people who think they're doing a good job are often fooled when they actually find out how precise it is required to get the resolution that
It's humbling.
we get.
It's humbling.
Yes.
Yeah, you've been doing this a lot longer than me. I've been doing this for 5 or 6 years, and I still can't nail it all the time the first time. But most of the time, we get really close.
Yes.
And but you know, that's taken many, 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 many years, and a lot of work and a lot of study.
Actually, owning a Tscan itself doesn't mean the user knows how to use it.
Yeah, for sure.
Unfortunately, even
It's an
basic
engineering
training
tool.
is not really, well, let's say it's not detailed enough to make someone a high-level user.
Right.
They have to train for a while and understand how to use it well before they can actually deliver care at a high level.
There's all these various philosophies and camps and dogma running out there. And dogma might be a strong word, but it really is. And when they can't reproduce something, they're not measuring. You know, they're pouring models, they're using paper. I mean, anyone with common sense realizes that paper and ink are not high technology. And it's analog, it's not digital. Putting numbers to things, and you're throwing electrodes over muscles, and you're actually proving the muscle shuts down. You know, you're not tensing them. You're not introducing anything artificial. You're doing something that's completely natural.
Yes.
You know, and all these dentists are bickering about, you know, the bite position, the this, that, and the other. And yeah, there's some partial truth to that, but most of the time, it's not indicated. The patient and themselves, it's logical for one to assume most people bite in habitual closure. And they do okay, even if they have the pain problem. If you want to get really serious about it, image the back. Take a joint vibration analysis, CT, MRI, all those things are out there. You know, most dentists have never even looked at an MRI of the joint, let alone a CT. You know, they ignore it when they shoot their big cone beams, their high-dollar x-rays, they know nothing about the joint. And, you know, it's a sad, it needs to change. You know, you need to measure the back, you need to measure the front. The back being the joints, the front being the teeth. So, and the middle is the muscle. The way I look at it, it's like the neurology. It's how teeth communicate to the central nervous system, and the efferent response resultant of that, how they interact in time. And I've talked to a lot of the supposed gurus or majors, whatever you want to call them, in occlusion over the years, and they simply don't get the timing thing. It's all about time. You know, you are measuring time, I'm measuring time in ways that they can't do with their plastics, their models, their paper, and their ink.
And their articulators.
Yeah, right. An articulator is a very poor substitute for the real joint.
Yes.
It's not a living thing. It's hard, mechanical. Instead, we were looking at something that has hard and soft tissue, it has give and fluid. You can't reproduce that with a ribbon, with an articulator. And I don't understand. It gets me frustrated because a lot of these patients that come to see me and you have been to good dentists. You know, they mean well, but they won't open their mind to understanding that timing makes a difference in a living organism.
Yes. They won't open their mind because they've been philosophized to believe in unproven methods and unproven principles that have pervaded dentistry for a long time.
Right. It's tradition.
It's tradition, it's credibility of leaders, right. It's politics, and it's also financial. The leaders have not adopted the Tscan technology or the EMG technology. They often will discount it in large lecture halls where they influence many dentists who
Sure.
might want to know something other than what's being taught.
I've seen that.
Yes.
I know you've seen that.
I've seen it many times, and
Yeah.
to the detriment of the dentist and to the detriment of their patients.
It's the patient that matters.
Yeah.
That's what really fires me up about all this. That's why I make the videos. The videos were primarily my effort to get your work out there for the masses, for the end user, because the bottom end of the day, what matters is the patient.
Well,
It's not about the bickering. It's not about the money. It's not about any of that. Stop the pain if you can. And oftentimes, you know, I would say, I mean, I'm just one guy, a third of the world's headaches are related to bite force and timing
Well, it would be a conservative estimate. but
across the board.
Yes. no
I'd say
question.
at least a third. And so many of these things are misdiagnosed. And it's our purview. And our profession doesn't even recognize it.
No.
You and I see it daily.
Yes.
Knock it out.
Yes.
And it's lasting. All the time? No. It's not a panacea.
No.
There is no one bullet cure for anything.
It has a very high efficacy for much of the problems that people suffer all over the world, actually.
Yeah.
These problems are in every country.
Yeah.
Occlusion and muscle tension and headaches and facial pain and jaw fatigue are very, very common symptoms. I see it in every country that I go to. And it's the same problem. It's a neurologic problem coming from the teeth.
Is it not true when you walk into a dental office and you demonstrate, I don't care where you are on the planet, when you want to demonstrate the Tscan, you need only look to the staff to find an individual that is amenable? Is that not true?
Usually there's at least one 20-year-old female or 20 to 30-year-old female who is a candidate for
Yeah.
having a T-scan evaluation for head and neck symptoms.
Your textbook that came out, it's starting to make a difference.
It's it's reaching a lot of people, let's put it that way.
Yeah.
But the original question, you know, what is the reason that in other parts of the world they might be more open to it, is really because the other parts of the world don't have occlusal gurus who
Right.
have resisted the technology
Right.
for the past 30 years. Instead of adopting the technology, the leaders in our country have minimized its effectiveness and minimized its importance.
It invalidates their take on things, everything they've taught over the years. They'd have to rewrite their curriculum. They would have to rethink what they're trying to state, get their message across. They would invalidate their entire, you know, philosophy and expose the dogma. I hate to say it.
It is dogma because
Yeah.
it's all unproven. It's a lot of theoretical approaches to how the occlusion should be, and the T-scan and the EMG together are proving what actually is going on physiologically from the occlusion,
Right.
and then it becomes very treatable. Right? When you can measure it, as you said, it's factual, and you can change it if you understand how to do that. And if they had a T-scan and they understood how to use it, and they put in 2 crowns, and they saw how bad the bite was on those 2 crowns, they would not leave them with a bad bite. But when they don't have the T-scan and all they have is marking paper, and the patient says, yeah, it seems okay, then 2 months later they have now TMJ from those 2 crowns. It's an epidemic. The biggest problem is iatrogenically caused by dentistry, whether it be orthodontics, badly installed prosthodontics occlusally, not necessarily badly made.
Yep.
Beautiful crowns that don't work occlusally will cause TMJ. Bad fillings will cause TMJ. Extracting a single tooth can cause TMJ. So
I've seen every one of
you've
those.
seen every one of them, and they continue to come in to your office and to my office with the same story. I had this done 2 years ago. I had my teeth ground on after I had whatever it was done. My
Based
bite
on the
changed
ribbon.
based on the ribbon only. My bite changed, and the doctor kept trying to figure out what was wrong.
And then my opposite side of my mouth started hurting.
And now I have TMJ, and no one
Now
can
I
help
pop
me.
and click, and I don't know where that came from.
I wore an appliance. The
Right.
appliance didn't help me.
All right.
Right.
Or made
That's
it
the-
worse.
That's the progression.
Yeah. And then I have to wear this appliance the rest of my life? I mean, I hear that probably 1 out of 3 people. I was given this appliance, it helps a little bit, but I don't want to wear this piece of plastic the rest of my life, says the 25-year-old female.
Right.
You know.
Exactly.
My take is, it's 2015, we can measure the front, we can measure the back, we can measure the muscle. Why don't we do that? So,
Well, those of us who are attempting to make a difference in this arena have been doing that, and there's a lot of research that shows it's very valid
yeah.
compared to the theories of many of the leading experts who have no scientific basis for what they do. We're trying to educate dentists in the correct methodology, diagnostically, procedurally, and to make intelligent choices about whether they're a candidate or not.
Right.
And without adequate training, they're not going to be able to get the resolution, that the patient is not going to get the resolution from the dentist that they're hoping for.
The biggest question we always get via email or phone call relative to the videos that I posted over the years is like, who in my area does this? I think we should make it known that we plan on building a certification process and a facility to start training other dentists on how to do this.
Yes.
You know, there needs to be somebody in every locale that has at least an understanding of what's going on here.
Yes.
And then the very smartest of the dentists are going to start realizing that there's huge applicability to everything they do all day long, you know, relative to setting up occlusions, relative to identifying problems, signs and symptoms. Signs precede symptoms.
Yes.
Wear facets, canine tips being worn down, recession, abfractions, popping and clicking, understanding of lateral versus medial pull, understanding of, you know, the neurology behind all of it, you know, periodontal ligaments. All this stuff needs to become more mainstream. Our training across the board in academia was horrible, and the psychology, I am so sick of hearing the patients say, I was sent to the psychologist, they said it was all in my head, and my answer is, yes, it is in your head, it's right about here, or up here. It's one of these two places, or both. Most of the time. Every now and then there's something aberrant that's going on, but that's a little more advanced. That's, fortunately, just a small percentage of the patients.
Yes.
Yeah.
Most of the patients' psychological makeup is due to living in chronic pain.
Right.
And it's not the cause, it's the effect of living in chronic pain.
You see all those patients that the dentist doesn't want to see again, that keep coming back, returning, wasting their scheduled time, they're the ones that find us.
Yes.
And we nail it most of the time.
Because of the measurement capability.
Right, because we can measure.
Yes, and the understanding of what measurements to make and how to correct.
And when to implement.
Right.
And when not to implement.
When not to implement.
And what not to touch.
What to leave alone.
Yeah, I mean,
it's
the static thing, the bite together thing, that is not it. It's this stuff. But it's more than that. It's not that simple. This is something we need to start passing on to the masses.
Yes, and we're attempting to do that, and I think in time there'll be more people who will be competent to do it. TMJ patients, if you will, that term, they're everywhere. They're in everybody's dental office, and they're not getting better with night guards and unmeasured occlusal therapy.
I'd say 30 to 40% of the patient population, I don't care where you live, has a muscular TMD problem. Probably, in my experience, in an average practice, from what I've read, heard, seen over the years, I don't know, 5 to 10 have a true, maybe a little higher than that, maybe 15 have an intercapsular issue. Actually, it's higher than that if you include lateral pulls.
True, you're talking about a true internal
Lateral, yeah.
derangement, yes.
Yeah.
Yes.
Something the DTR can't treat would be a really messed up medial pole, effusions, you know, torn cartilage, something that's a bony problem, a component. My point is, that's a structural problem, right? That's a relatively small percentage.
Yes, comparatively to the
Yes.
chronic pain patient. And those patients who have structural abnormalities, there are modern methods to approach that as well. Certainly
Ways to
imaging,
measure it.
Ways to measure it, ways to see it visually, sonically, and digitally, again, all very computer-based methods. And there's some acceptance to a degree of that, but again, not on a widespread basis. And that has to do with, again, the lack of acceptance of the occlusal world to the need for technology in diagnosis and in treatment. The sad part is that dentistry wants the dentists to believe that the paper marks are telling them these things, that the paper marks don't tell anything at all. I'd like to see the leaders change their tune and realize they're missing a lot, and that they're teaching their dentists ineffectively about the truth about occlusion. That is numerous studies about that involve measurement that are being neglected and not talked about, not referenced, not cited, and the journals, many of them resist publishing technology-based occlusion studies because they somehow think that they're helping the dentists learn by blocking these very important studies from being accepted.
There's a political reason for that, I'm sure. It has to do with so-and-so that they happen to know who's on the board of directors of whatever institution we're talking about. They're all connected. You know, don't want to invalidate what they're doing.
Well,
I mean, it's politics and money.
for
But
sure.
like I said, the end game is helping the patient. I think over the next year we need to figure out ways to train other people, get a certification going, figure out a way for patients to find docs that are properly trained and don't just say that they do DTR, for example. It's
Yes.
more than just DTR.
Yes.
You know, I call it that neural occlusion thing. You know, the whole putting it all together, measuring the back, measuring the front, measuring the middle, the muscle, the neurology. I mean, we're still learning ourselves. I mean, I'll learn till the day I drop. But it's amazing when you can start making things a little bit more predictable. But like I said in the very beginning here, we can never predict 100% of the time. We got to
No.
do it. And you,
Right.
I know you know.
Yes,
better
the
than I do.
patient has to go through the process.
Yeah.
And it's not a difficult process, and the vast majority, you know, rapidly have less symptoms, and I mean rapidly, within, you know, 20 to 60 days, they have less symptoms, you know, very, very often, almost all the patients. And certainly there are some that take longer to heal, and others that heal very fast, but usually within a few months' time from the first treatment session, there's a noticeable difference in the problems that they have.
Yeah.
And very few treatments that we have other than DTR, measured occlusal changes, can offer the patient that. You know, absent of a splint, no tensing, no physical therapy, no muscle injections, no Botox, no pain meds, no external treatments for the vast majority of people. And this is not new. This has been in the literature since 1990, right?
Right.
And maybe even a little bit before that, but studies since 1990.
Right.
Your reach with the videos has been what is propelling the change in thinking for many dentists who have been indoctrinated in the other theories.
I've been told by numerous sources from all over the place that there are patients walking into dental offices, not only in the U.S., but all over the world, asking them if they do DTR.
Yes.
And
Yes.
the dentists are like, what is DTR?
Yes.
At least they're thinking about it now.
Well, disclusion time, which is what the DT part of, has been a known clinical problem since 1990. Right. So.
Well, it's time for everybody to wake up and start paying attention.
Yes.
That's all I have to say.
Yes, I would agree. And a lot of that has become possible because of what you've done. And you have to be commended.
Notwithstanding with what you've done, you're the one that did the hard research.
Yes,
Yeah.
but the impact of the research has been validating of the method, but not embraced by the profession. It's been resisted by the profession.
Well, get it to the end user. That's the whole point of the videos.
Yes, and the end user is the one who needs the therapy.
Yeah. The U.S. alone, there's what, 20 to 30 million people that need it.
Yeah, well,
Probably,
they say 12
let's-
to 20 million TMDs.
Yeah, let's say 1% show for treatment. I mean, that's a lot of people. Take away 2 zeros off 20 million. What have you got? 200,000.
200,000.
I can't treat 200,000 people the rest of my career.
None of us can.
Yeah.
We can't see them all, and there's so many that they're going into dental offices asking if the therapy is available there.
Right.
And the key point, though, is someone seeking care should realize having a T-scan or having an EMG doesn't make you a T-scan expert, and it
Yeah,
doesn't
for sure.
make you a DTR expert in any way.
It can almost make you dangerous if you're not trained properly.
Yes.
Yeah, like
Most-
anything else.
Yes, most T-scan users, they seek out more and more training because they find as they use it that there's a lot in there that they're not able to glean in the early stages of use, and only through advanced education can they get there. And so that's what the purpose of having certification would be, to make it possible for someone to take their T-scan knowledge to a very high level, and then they could deliver that high precision that we're talking about to their sphere of
Affected
influence.
change.
Yes,
It's positive.
no question.
Thank you, sir.
Thank you. We wouldn't be here without you.